So I would like to welcome everybody to this session, which is a sponsored symposium by First Kind Medical. It's looking at embracing innovation and update on a multi-centre randomised self-controlled trial, or RCT, using the geko device for post-stroke unmet need VTE prophylaxis. And joining us today to give this presentation is Dr. Indira Natarajan. It would be really good to have Dr. Indira back because he's spoken before, but now the trial is up and running, we will be able to learn more. Since his appointment as a consultant stroke physician in 2008, Dr. Indira has held various leadership positions within stroke care, both regionally and nationally. He's always been a champion ambassador for stroke victims with roles in Midlands Stroke Clinical Network and University Hospital of North Midlands NHS Trust, and has raised the profile of services in all aspects of care, from stroke prevention to end-of-life support for stroke patients in the community. He is also widely known for all of his innovative work. Dr. Indira has pioneered innovation in this area of interface, working for stroke prevention in patients with arterial fibrillation and the introduction of Sky Medical Technologies' geko device as an adjunct to current VTE prevention guidelines, which has benefited a lot of stroke patients. He's played a key role in winning several awards for innovation in stroke practice, including the Health and Social Awards for Stroke Services and the Healthcare Pioneers Award, showcasing best practice in AF, presented by the Atrial Fibrillation Academy. So this afternoon, I feel very honoured and delighted to welcome Dr. Indira, who I'll pass over to now. Can I just say he will welcome taking your questions and comments or points for discussion. So please feel free to post them either in the Q&A or in the chat, and we will catch up with those after his presentation. But for now, over to you, Dr. Indira.
Thanks, Joe. Thanks for the introduction, and thanks for all the people who are joining to listen to my talk. The title is a long title. It's actually a journey that we had taken because there was an unmet need, and I'll try to explain as I go through my presentation what was the unmet need. So the area that I'm going to focus is one of the commonest complications of post-stroke patients because of the nature of the disability. VT is one of the big complications post-stroke. So just to give you a flavor of how big the problem is, at present, this is slightly old data, that around 110,000 people are admitted to hospital with stroke each year. And it is anticipated that the post-World War baby boom is going to increase the stroke numbers to much a higher level. We anticipate it's going to hit around 150,000. That's the estimated prediction. With the data of 110,000, around half of these patients, when they are admitted to the stroke unit, for a variety of reasons, they are disabled, they are unable to walk straight away. And the numbers are coming down because of interventions like lysis and thrombectomy, but still we are dealing with around half of our patients who can't walk. And sadly, a proportion of them die within 6 months. As you are all aware, there are two types of stroke. An ischemic stroke is caused by a blockage of a blood vessel, and the brain is devoid of oxygen and blood supply, and that's called an ischemic stroke. And 15% of our strokes are caused by a rupture of a blood vessel with leakage of blood into the brain parenchyma and causing the disability. Right, so VTE, venous thromboembolism, is a preventable cause of death in hospitalized acute stroke patients. The word VTE is used for both deep vein thrombosis and pulmonary embolism, or both. So a deep vein thrombosis, as you're all aware, is a clot that develops in the deep veins, most often in the lower extremities. And pulmonary embolism is the same clot that just breaks off and travels to the lung, potentially life-threatening. Data shows that around 20% of the immobile patients will develop a VTE or DVT, and of that, around another 5% will develop life-threatening complications like pulmonary embolism. So just to go back to basics, who are the people who are prone to develop VTE? And either they have stasis of blood, because of immobility, or if the blood is thick because of a variety of medical conditions, or if there was a vessel or injury that can provocate a formation of a clot. So either one of these can trigger a formation of a clot, particularly in the deep veins of the legs. And in stroke patient, the reason for them to form stasis is there is a loss of a temporary or a permanent loss of limb movement. They are in bed for a prolonged period of time. Once they are in bed and not active, your muscles, which normally pump blood, becomes wasted and weak, and they lose the important calf muscle pump activation and function, which pushes the blood and prevents VTE in in the general population, like people who are walking. So increased risk of stasis is because of all these reasons. So as clinicians, as in frontline clinicians, what are the options we had to prevent VTE? So in the past, we used to use graduated compression stockings, which are still used in post-operative surgical patients. And I'm sure you would have all recognized these white stockings, which all patients in theaters or post-operative surgical wards or in intensive care we used to use them in stroke patients. An intermittent pneumatic compression device is called the IPC. I'm sure you would have seen this. This is like a sleeve along the calf muscles, which is connected to a pump, and the pump gradually inflates and deflates pressure so that they squeeze blood from the calf muscles into the circulation, preventing stasis. Or a blood thinner called the anticoagulants. It's a low molecular weight heparin, which is given as an injection form once every day to prevent the clot formation in the deep veins. Or the best method is early ambulation. So earlier the patient starts to walk, the better the pumping mechanism and preventing stasis. Amongst all, the best thing is early ambulation, but unfortunately, on the stroke unit, we noticed that 50% of our patients can't walk, so we had to rely on mechanisms to prevent clot formation in their legs. So, what was the limitations? The graduated compression stockings, which was used across all the stroke units in England, once the CLOTS 1 and CLOTS 2 trials were published, that it was ineffective after stroke, we got rid of all the boxes of stockings, and none of the stroke units in the whole of the UK use graduated compression stockings. Until they've had a stroke post-operative, we don't use stockings at all. IPC has got evidence, and I'll tell you what is the evidence and how we started using it as part of guidelines. But there are issues with compliance. And drugs is an easy way because you know that when you give the injection, the drug is into the system. But unfortunately, with post-stroke patients, it is very clear that a low molecular weight heparin causes high risk of bleeding in the initial periods after they've had a stroke, particularly ischemic strokes. It causes hemorrhagic conversion, and the outcome and the disability and the mortality is higher in this group. And already, if you had a hemorrhagic stroke, you can't use these low molecular weight heparin drugs. So the evidence came from the CLOTS 3 trial for IPC. IPC stands for intermittent pneumatic compression. This trial was led by Martin Dennis and his team from Edinburgh. It was a large randomized controlled trial, and they assessed the use of IPC over no IPC in acute stroke patients. They measured the VT incident in 30 days, and the results showed that 30% reduction in DVT and 14% improvement in overall survival to 6 months. Because it was a RCT, it was class 1 evidence, so that became a sort of guidelines for VT prevention across the country. So NICE guidance recommended IPC immediately post-stroke within 72 hours of post-admission. But clearly, as they approved IPC, they also said the use of drugs, that stockings and heparin is not recommended, and only IPC was the first line treatment for prevention of VTE. So this was the data from the CLOTS 3 trial. And if you could see that with IPC in clots 3, the VTE incidence was only 6.6%, whereas in patients without the IPC, the VTE incidence was 8.7%. And as I said, unlike drugs, these are devices. And if you're reliant on a device to prevent VTE, this has to be worn 24 hours a day. It's no point in prescribing a neuro mechanical device without being monitored for being on the patient. So what straight away the things that was picked up was that 30% of the population or in the study group, they couldn't tolerate IPC because either they had contraindications or it was extremely difficult for the patient to keep the IPC for a 24-hour period. So that came around to around 30%. And the adherence was also quite low. So if you want a treatment or if you want an intervention to prevent VTE, or if you follow the guidelines, if you had 100 patients on the stroke unit, every patient should have a mechanism in which the VT is prevented. There is no point in having a licensed guidelines which only is good for 70% of the population. What happens to this 30% of the population? So we felt that there was a gap in our VT prophylaxis for people who could not tolerate standard of care, which was IPC. And we didn't want to go onto the drug route because we clearly knew that the risk of bleeding was high. So we were caught between a situation where we had a group of patients who couldn't tolerate IPC, and at the same time, we couldn't go on to drug interventions because of the risks of a bleed. So we thought, right, we need to find a way where we have to embrace new treatments of care and to challenge the status quo for better patient outcomes. And this was the driving force in seeking an alternative intervention when IPC cannot be prescribed. So to make the point clear, for every patient that's coming through the stroke unit, we always make sure that they have IPC as the first line VT prevention on top of aspirin, on top of nutrition, on top of intravenous fluids and early mobilization. This was standard of care. Only when we were not able to use IPC because of contraindications, or they're not able to tolerate, or if they've had an ulcer, if they had a lymphedema, or if they had arterial disease, that was the time we thought, right, we need to look into something else. So that is a time where we came to be aware of this neuromuscular electrostimulation device called the geko device. And the way the geko device works is I'll show you where it's placed and how it looks in a minute, but this stimulates the common peroneal nerve and activates the calf and foot muscles, increasing blood flow in the deep veins of the calf. And NICE recommended its use after stroke when your standard of care is impractical or contraindicated. And this led us to see whether is this what an alternative in real world. We wanted to do an observational analysis in a form of an audit to see. First of all, we wanted to see what was the level of the unmet need. Was it exactly the same as what was came in CLOTS 3 trial? And we wanted to see between the geko and the IPC, is the geko tolerable? And is this an alternative when patients can't have IPC? And at the same time, we wanted to see what was the incidence of VTE at a 90-day follow-up. So that is the geko device. That looks like a sort of a plastic wristwatch. It's got a battery and it's got two sort of plus and negative signs where you can increase the generation of power. So when it's you have to apply this device around the head of the fibula, and that's where the common peroneal nerve runs. And the way we know that the geko was working is you slightly have some sort of a dorsiflexion and plantar flexion of the toe. And if that's not happening, we just increase the frequency on the plus sign, and then we'll see the movement, and then we know that yeah, it is working. It is stimulating the peroneal nerve, and blood is flowing. So before we want to put into practice, we know that there is an alternative. We know that there is a group of patients who can't tolerate standard of care. Is it safe? Is it going to really benefit our patients? Can we adapt it? How can we collaborate between all the healthcare professionals? Is this going to be another exercise where we are going to be fatigued and give up? So anything in terms of introduction or change to clinical practice can be complex. You need to go through a lot of hoops, and the hoops are necessary because you're trying it on patients. We need to make sure that patients are put in the center of this, make sure safety is paramount. So what we did was we set up a project team. We went through divisional governance and VT steering committee. These are very tight bodies where you demonstrate what we're going to do. We went through the inclusion and exclusion criteria, how we are going to recruit patients, how we are going to monitor and monitoring and outcome follow-ups. We had to liaise with the hospital pharmacy because although it's not a drug, it has to be put on a drug chart because only when you sign it, we know that it is applied to the patient. And more importantly, the most important thing is everybody needs to be trained to apply this device, and not only training. And what I'm going to say now is very important for IPC and gecko as well. It has to be on the patient 24 hours to prevent VTE. So we needed to have people who will do around 3 or 4 times in a 24-hour period to make sure that these devices are on the patient. Because unlike drugs, if they are not on the patient, it's not going to be effective. And many a time when I've done ward rounds, I've seen these sleeves on the floor. That means that the patient has been unprotected for the number of hours the patient was not having the sleeve. So it was a tedious process to set up this. And we initially thought, right, okay, we will do it on 1,000 patients between 2016 and 2018. That's the time period for us to collect the data. It took 18 months to complete. And all of them were having a gecko. Sorry, we required the gecko user training. We identified people on every shift to make sure that they have the 4-hour mandatory checks. We need to see whether they had correct fitting of the IPC and the gecko device, and also monitor patient compliance. So as I said, the first thing was patients unable to mobilize independently were prescribed IPC alongside hydration, mobilization, or aspirin. If the patient were palliative or they're fully anticoagulated or refused the intervention, we do not put them on into the gecko arm. So if they couldn't get the IPC because of intolerance, skin irritation, they were switched to gecko device. Or they started off with an IPC and they couldn't tolerate the IPC, then we switched to gecko as a secondary intervention. And all throughout the study, they were regularly followed up with VT outcomes at 90 days. So that was what was our measure. So of the 1,000 patients that we had this, as I told in my first slide, around 688 patients required an intervention. So they needed either IPC or a gecko. And 203 patients were straightly get onto gecko because they were contraindicated or they couldn't tolerate to IPC. So that represented around 29.5% of the 1,000 patients, which clearly was in match with the CLOTS 3 trial, where they felt that 30% of the patients could not tolerate IPC. Our VT incidence in 90 days were 2.5% in patients prescribed IPC alone. And surprisingly, we didn't see any VTs in patients prescribed gecko device during this assessment period. And the tolerance was well tolerated, 90.8% adherence compared to 78% on IPC. And what improved our practice during this phase was we had the 4-hour mandatory patient check maximized adherence to both modalities. So patients, even with IPC, were monitored so that they had the IPC throughout the 24-hour period. The battery life of the gecko device, they say, is around 36 hours, but the device has to be changed on both the legs every 24 hours, and they have a separate way of disposing the device. The average duration of use, either for IPC or gecko, was 5 to 9 days, or until a patient was mobile and no longer needed BT prophylaxis. So, with that real world data, that changed our practice in our stroke unit. And the gecko device is now routine for unmet need BT prophylaxis, meaning that we can now offer 100% VT prophylaxis for all our acute stroke patients, unlike where in the past we had this 30% of population who were neglected, or we couldn't use standard of care and we were a bit reluctant to use a low molecular weight heparin. And also, this led to a 46% reduction in VT in our unit compared to the time before the gecko device was used. So now across our unit, we clearly know who's on drug, who's on IPC, who's on gecko, and we have now got another equipment on our sleeves to make sure that VT is on top of our prevention. And this was providing a greater peace of mind so that we are not neglecting a group of patients because we couldn't prescribe them a standard of care. So, as I said, the key thing that changed our practice was the surveillance. That's very, very important because you're not giving drug. So these devices has to be monitored. The real world data which we presented influenced other NHS stroke units to come and see what we've done, seen the uh, challenges that we had to face in getting into clinical practice. And all the other centers consistently reported that their unmet need is close to 30%. So this is what the reason why they came around and they took back our pathway. And there are several units across the UK which have gone and changed the practice on top of standard of care. The clinical audit is continued in our unit, and just purpose of time, if anybody requires, the slides can be shared. You can look at our poster that we've presented, which gives us about the details of all the data that we've collected, which we've put it in a nice flowing pie charts. Right. So now we are now moving on to the next phase. Like anybody asks, okay, you got something in your hand. Is that where you're going to stop? Are you happy that you got a device that meets the unmet? We now thought, right, let's go on to the next step to see whether the gecko device could be proved more effective than IPC in preventing post-stroke VT rather than used for unmet need alone. Why can't we just say we can compare a head-to-head multi-center RCT to see the use of gecko versus IPC? So this has been funded by an NIHR grant. Site recruitment is commenced, and the study is run jointly by stroke survivors, clinical researchers, stroke physicians, academic staff at Keele University, and the device manufacturers itself. So these are our primary objective. We want to hit around 1,200 patients. We want to study the outcomes between two devices, the IPC versus the gecko. Secondary objective to compare our safety and patient tolerance, survival, functional outcomes and quality of life, health, economic and environmental impact. So it's a prospective multi-center RCT, at least 10 study sites in England. Planned enrollment, we're planning 600 per arm. The treatment duration is 30 days or until the patient is independently mobile or discharged into the community, whichever is the easiest. The follow-up duration is 3 months. The randomization is 1-to-1. So at time of randomization, we'll know whether the patient is going into the gecko arm or to the IPC arm. So this is like the flow chart. We know that the patient is immobile. We know that the patient probably needs VT prophylaxis. We do a baseline assessment. And once we know that the patient needs VTE, after inclusion-exclusion criteria, we randomize. They either go to the IPC arm or the gecko arm. We do a Doppler ultrasound of both the legs, day 7 and day 14. And now we are thinking whether we can just get out of the day 7 and just go for Doppler ultrasound on day 14. and we stop analyzing the day. I mean, the study stops at either day 30, or if they're discharged, or if they're moving into the community, and then we have a phone call up on day 90. One of the problems in rolling out very quickly is centers getting the Doppler ultrasound as a part of study on patients who are asymptomatic, because we are trying to see whether we're picking up asymptomatic DVTs. Obviously, during this whole course, if we pick up any symptomatic and DVT and PE, that would be picked up as an outcome measure. So that's the sort of the whole journey of the study. So basically, we have aligned our practice to the NICE guidelines. NICE did support the use of geko device for unmet need. And what we have done is we have made sure that the unmet need is supported by a device which can be tolerated, which is safe, and which also can be adopted in our standard clinical practice. And that is what we went through a journey. We now met the unmet need, but now we are moving on to the next phase to see whether the IPC or the gecko, either is it superior or is it non-inferior, and if it's non-inferior, and this could change the landscape of VT prophylaxis management in post-stroke patients. So if any one of you want to know more about the gecko device, either you can contact me or make arrangements to visit our unit or visit our booth at this event. And I'm happy to share the slides, and you got the link to the PDFs of all about our real world data. So you're more than welcome to download and analyze. And I'm happy to take any questions, and thank you for your attention. And thanks for the opportunity this year to present this across to all of you.
Thank you, Dr. Indira. That was very interesting. And you've certainly come on quite a journey of learning, testing, and being certain throughout this process, haven't you? But always with the outcomes being key to what you've done. There are questions that have come in, and I will go to those. One is, with you, one of the things you highlight is that it was critical that each patient was checked every 4 hours to make sure the device was still on properly and therefore doing what it needed to do. When you're dealing with new staff or locum staff, were there any issues, or how did you overcome those problems to ensure that gold star practice continued?
Right. Okay. So what we do, Joe, is there are two folds to the question. The first fold is we run a 3-monthly stroke school for all the staff who are joining the unit. And gecko training and VT prophylaxis is part of the program, along with all other aspects of stroke care. But what we also have is we've identified 4 or 5 nurses who are sort of VT champions. And the reason why these champions are identified is when we have student nurses come in through particularly the take, or we have agency nurses, we make sure that they are given that sort of a training on a one-to-one basis. And also we identify on the road if there are any people who are not trained in looking at the adherence of both IPC and gecko. And as I emphasize, I just want to emphasize, this is not a drug. So you can't just sign it on a prescription chart and think, all right, job done and dusted, unless until these people wear it 24 hours. So that changed the landscape of our practice, because we had mechanisms in place that it's like in a routine round, it's all checked that these patients have these devices on the legs.
Thank you. You also said, there was high compliance with this, I think in 92%. But has there been any issue that you found with maybe any skin damage or any issue for the individual? And if so, were there things to overcome?
When the device came in, the first thing that I was, or all the clinicians were worried was, oh, how are we going to tolerate something just irritating your peroneal nerve? Is it something that you can wear and sleep? These are the questions. So what we did was we did try it on ourselves just to see, is it tolerable on a sort of a person who's normally walking? So the first 5 or 10 minutes was, you're aware, but then it becomes, you just get accustomed to it. And that was a specific question that when we had feedback from patients, we specifically asked. And when it was explained to them that this was to prevent clots and this had a purpose, it was not in the peritic arm that was felt. It was slightly felt in the non-peritic limb. But it didn't disturb sleep. But the thing that we came across was some allergic skin reactions to the gel that is used to attach it to the common peroneal nerve, like a local skin irritation. So now the company has taken that feedback and they are looking at an alternative to reduce the skin irritation. I think they're using something called the hydrogel, which so that's something that was a feedback, and that's the only major complication. And the one other thing that we also noticed, that when you do an ECG with the patient on geko, it produces some sort of abnormal pattern on the ECG. So you have to be conscious and mindful that you take the gecko out when taking an ECG, and or if they're going for a brain scan or MRI scan, these needs to be detached. So those are the things that came across.
So on admin as well, you need to be careful, but they are overcomable. It just needs to be
Yes,
awareness and then put into place.
absolutely. Just the awareness of when to remove and what are the things that you need to look for.
Good question here is, can it be used, because obviously I'm sure you see lots of patients like this, can it be used for patients who are frail, temporarily and deconditioned to regain function, but not to independent mobility? So can it be used on very frail patients?
It can be used on frail patients. In fact, it's quite easy on frail patients because the peroneal nerve is very, very prominent, because there's less muscle mass. So you can easily identify the peroneal nerve. Um but it doesn't. If the question is whether it sustains muscle mass, no, it doesn't sustain muscle mass. It's not like walking, or it's not like doing exercise. It only stimulates the peroneal nerve, and it only pushes blood from the deep veins. So its job is only to squeeze the muscle, but it will not sustain to prevent muscle wasting. So if that was the question. So if somebody is thinking of using it for preventing wasting, no, it is only to prevent circulation.
Okay, thank you. This, I think, is perhaps further down your journey, because there's a question about whether it might be effective in non-stroke patients where heparin is contraindicated, and if so, could it be cost effective? I'm presuming that's somewhere in the future, but has any work been done on that?
Now,
Is there any
that's a
idea?
very interesting question, and that's my next area to say. Right, there are a group of patients, or if there was the general population as a whole, or even in hospital, we are moving away from non-pharmacological interventions. Right, for every medical condition, drugs are not the first choice. So, like treating hypertension, I emphasize on lifestyle, salt reduction, healthy eating before you start them on a drug. So, we are planning an RCT on non-stroke patients, comparing mechanical device versus low molecular weight heparin. Probably that will answer that question, but that's for in the future.
Okay, thank you. This is a good journey. A few practical issues or questions related to that again. So, could the device be used on a limb with a fracture?
Yes, there is no contraindication. Even with a fracture that is fixed with internal fixation, it will not cause any problems.
Okay, thank you. And also in sharing these with patients, or depending how unwell they are, with their family or carers, has it been difficult or challenging sharing any of the information about it? Have you found any tips that would work well to help them understand and tolerate it beyond those first sort of 5-10 minutes when it may be more prominently uncomfortable, just as they get used to it?
Yeah, I think the way we went around was we always said standard of care is first line, like hydration, aspirin, fluids. And when we did the IPC, and when they're not tolerating the IPC, we did explain to the patient where they were able to understand, or if we are making a decision on behalf of the patient, the families were involved. So we were not directly putting these on. For IPC, we don't need to ask permission because it is within the guidelines. But when we were using this during the period, we were explaining to them why we are using an alternative mechanism. to explain that it's for the benefit of the patient that we are preventing, aiming to prevent formation of a clot. And there was no resistance even from the patients or the family. I mean, the majority of the time they did say, do what is right for the patient. But if there were a few relatives or families, because this was not evidence based, or so they were not keen, and we didn't include that group in. And that was a very, very small group that we didn't include that in our observational analysis.
Okay, thank you. Looking at somebody's raised this question, that is there any plan, probably by the company, to be able to replace the batteries rather than have to replace the whole device each time? Or is it still quite cost? I mean, obviously there's an environmental issue with the disposal, but otherwise, is it quite cost effective as if not?
I have asked this question to the company and the manufacturers. I think changing of a battery would be very it takes a lot of time, because that will be a dedicated time. It takes a lot of staff away from, because if you have a 32 bedded stroke unit, and if you have 24 patients who needs to change battery, it becomes, although it sounds a small number, it will take a lot of carrying time away from patients. So what we asked the manufacturers was whether they could increase the battery time. Rather than changing it to 24 hours, we asked whether they can make the battery life 48 hours, so that we don't need to change it every day. We can change it every other day. So that is something that they are looking into. So that might be for the future, but changing the battery would be a sort of logistic nightmare.
Yeah, and I'm sure that will also go down into logistics and ordering and
Mm.
the administration that goes with that, which is challenging. Looking at some of the work and the research, do you know if the geko device is financially difficult to implement, or was there any comparison of the cost of the geko device against standard of care that helped you to bring it into your practice?
No, it all depends on procurement. That's where, as a clinician, it's quite difficult for me to answer that, because because it is we modeled our cost for getting these based on our unmet needs. So 30, when we felt that 30% of our patients would need it, so our procurement was higher compared to what we would have normally done. So matching with the IPC, the cost was not substantially different.
Okay, thank you. Looking at the RCT, which is really interesting, is the recruitment from UK sites or is it international?
No, it is only it's on the UK sites, and for because of the ultrasound that we need to get on patients for asymptomatic, because that's the key. We're only running it in Midlands because we know the sites are closer. They've already adapted, and we know the team. We are trying to roll it across England if any site is interested. But at present, the sites that are active are within the Midlands.
Okay. And then again, if people are in that area or want to find out more, thinking about how they could do this in their area, do you have any business plans, first of all, if they wanted to trial them or to join the RCT? How is the best way to contact you or to find out more information about it?
They can just email to me, and I can channelize them to the appropriate people. So the person who runs the trial, who's the national PI, is based in Kiel and works with ourselves. Or if you want to do it as a pilot, there are lots of sites who have done it as a pilot. We are more than happy to support whatever they want to do.
Okay, thank you. And I'm sure that peer-to-peer support as well as the information would be really valuable.
Mm-hmm.
And if anybody doesn't know Dr. Indira's email, if they want to email me, with his permission, I can pop
Hey,
it.
absolutely. Feel free. That's the whole purpose, to reach out to clinicians who are just thinking, all right, I want to look at something else, alternative. How do I go about? What are the challenges we felt? We're happy to share all those details.
Um, how long was the RCT likely to be running? Do you have a sort of timeline?
Our target is around 2 years, because of the numbers of patients. And so 1,200 is our target. And once we hit 1,200, we are optimistic, but at the same time, we are just, we don't want to be over ambitious. So once we hit the 1,200 mark, 600 on each arm, we will be able to share the results.
And is there a closing date by which time people you're looking for people to be contacted?
At present, I don't think so. We are, if anybody's interested, I'm more than happy to be contacted.
And I guess from that point, and the question is there any support if there's any extra work on running the RCT in their centre? Is there support for that, or will it be very burdensome?
If they want to do an observational a study, or just like a pilot, we can try and get some support. But if it's an RCT, that has to come from the PI. So there will be some sort of a support, because it's got an NIHR grant attached to the study. So the lead PI, who is Professor Roff, will be able to talk us through that.
Brilliant. So contact and you'll be able to find out more. And I think the last question I can see is, in orthopedic patients with recent lower limb surgery after low molecular weight heparin period, some of them are being discovered with DVT. Do you think there'd be a possibility of a trial with this device straight after surgery?
Absolutely. That's so that's one of the areas. If any surgeons interested, we want to work with them to see whether, as an adjunct to low molecular weight heparin, we can do an arm where they just go standard low molecular weight heparin with low molecular weight heparin and the device, to see whether there is a difference, because orthopedics is one of the areas where the peris is very high. They are immobile for a varied period of time. So this is where these are the areas that will be interesting to look in. If anybody is interested, more than happy to collaborate with them.
Thank you. So lots of information already, exciting stuff being undertaken, and potential for the future as well. But I guess the starting point, if people want to find out more or come and visit, see it in action, is to make contact with you.
Absolutely.
And build from there. Thank you. I think we have exhausted all the questions. Is there anything else you'd like to add that I might have missed or you may have seen? I can't see any more questions. I know Sue from North Bristol is keen, and I think has been in contact with you as well. So
And one of the question was, when do you stop device? What is definition of mobile? So the definition of mobile is they are standing, and they are able to keep their feet, walk with aid, without aid, and are able to do that more often, rather than they're spending more time ambulant. So they're going to the toilet. They're able to do activities of daily with or without support. That is a time when we think, all right, now they're ambulant, we'll stop it.
Can I just ask, is this a device that is just used in the hospital care? They're not discharged with it?
No, no, because it needs some sort of knowledge and education to put the device, and it has to be changed every 24 hours. So it is limited to only in hospital and never being sent out.
I think we have exhausted everybody's questions, but please, any more questions, do get in contact with Dr. Indira or via the stand. Really interesting, as it's coming through, really interesting presentation and lots of answers. Thank you very much, Dr. Indira.
Thank you very much, and thanks for the opportunity once again.
Pleasure. Thank you. Bye-bye.